Agency for Toxic Substances and Disease Registry Community Assistance Panel for Camp LeJeune. I am John Decker. I'm from the National Center for Environmental Health and ATSDR Office of Science. I'm the Associate Director for Science. I'm filling in for Dr. Bricey this morning, who's at a meeting with the CDC Director, and he will be joining us later in the morning as soon as he can. I would like to remind the audience and the CAP members that the discussion is being recorded through a transcription service. So please speak into the microphones to ensure your comments are heard and transcribed. At this time, we should go around the table and do introductions. Again, I'm John Decker from NCEH and ATSDR.
Good morning, Commander Jamie Mutter, DT-HHS, CAP Coordinator.
Good morning, Patsy Kerr. I'm standing in for Melissa Forrest with the Department of the Navy.
Tim Templeton, CAP member.
Brad Floor, VA.
Ralph Erickson, VA.
Brady White, I'm at the VA.
Kevin
Mike Ashkins, CAP member. Mike Partain, CAP.
Sarah Blossom, University of Arkansas for Medical Sciences, Scientific Technical Advisor for the CAP.
Chris Soros, I'm a CAP member.
Danielle Carraza, CAP member.
John McNeil, CAP member.
Jerry Ensminger, CAP member. I'd like to add that today, 22nd of August, it's 20 years that I've been involved in Camp LeJeune, since I've known about it.
Rick Killig, ATSDR.
Frank Bove, ATSDR.
Perry Ruckert, ATSDR.
Mike Ashey, CAP member.
Again, welcome to all the CAP members and the audience who have come here today. I'd like to make a special welcome to the Canadian Broadcasting System who is here filming today. Please be advised that CAP members and visitors may be filmed. If you do not wish to be filmed, please, there's a sign-in sheet at the front that you can put your name on where they can later blur out your faces. Or if you want to talk to Heather Bear Brake, who is somewhere here in the room, or she stepped out, Taka here in the corner you can talk to as well related to that. Are there any other logistics? If there's a fire alarm, do you have?
You had to ask me that, right?
Yeah. What are the directions for that?
I will find out and get back to you at the next one.
Okay.
I assume it's out this door at the end, down to the parking lot.
Right.
That's my assumption, but I will confirm. Is that right, Rick?
That's correct. Okay. Right. And then the restrooms, of course, are just outside this room and down the hallway in that direction. I'd like to remind the members of the broader community that this is a CAP meeting, and while we're interested in your questions, there will be a period of time on the agenda for those. It's about 12 o'clock according to the agenda, and so if you could hold your questions and concerns until that time period, we would appreciate it. While I'll try to keep us on the agenda times, the time on the agenda are estimates, and we don't want to cut off any important discussions, so there may be some flexibility in the times listed here. I think that's it. Anything else, Jamie?
Cell phones.
Cell phones, please mute them or turn them off. Thank you. And I think we can get into the agenda. Our first agenda item are VA updates. We have Mr. Brad Floor, Mr. Bradley White, Alan Dinsman, and Dr. Lauren Ralph Erickson here today for updates.
Yes, good morning. So this is Ralph Lauren Erickson, and thank you for, again, inviting us to participate. Very much appreciate being part of what I think is a good representation of a whole of government approach, in that the ATSDR, as part of the Department of Health and Human Services, sponsors this particular community assistance panel. However, we at Veterans Affairs, a sister agency, and also Department of Defense, a sister agency, are invited as guests to participate, and we very much appreciate that. To let you know, this particular community assistance panel is very important to the leaders of our agency. To sort of underscore that, on a regular basis, we brief our senior leaders on things that we bring back from this particular meeting when we come. In fact, in another just 2 weeks, I guess. We're really just 2 weeks out now. Both Mr. Brad Floor and I will be briefing the Secretary, in fact, giving him an update on a whole host of Camp LeJeune issues, some of which we'll be discussing today. So again, we appreciate being guests and being able to participate with you on this important issue. We have a few presentations to give in the time that we're allotted, though we know that there will be additional questions. We'll be starting out in just a moment with Mr. Brady White, who has some slides that are on the screen. Thanks, Jamie. And Brady will be giving you an update concerning the execution of the 2012 law, the Janie Insminger Act, as it relates to providing health care to veterans and last payer payment of hospital bills, health care bills for family members. I'll just mention that literally the numbers that you'll see here are the numbers that we brief to our senior leaders to update, and they'll ask questions about what can we do better, how can we facilitate this. Following Brady White, we'll have Mr. Brad Floor talk about claims, and he'll give you some update on the claims issue. Now, for those that are not aware, there will be a difference between what Brady is presenting and what Brad is presenting, in that the 2012 law, the Janie Insminger Act, has a list of 15 conditions that are listed, and that law is fully in effect. The claims that Brad talks about includes claims for 8 presumptions, which is a separate list. There is some overlap in the diseases between the two lists, but a separate list, and this in this case applies only to veterans. So I just want to tell you ahead of time, there's always potential for confusion between the 2012 law and how we're executing that and the presumptions that are now in place since March of this year. Also, I hope we have on the line Dr. Alan Dinesman. Alan, are you on the line? Alan, are you on the line?
Good morning. Give me a second to get off mute. I am on the line.
Okay, very good. Yes, I get caught with that mute button as well. And so Dr. Dinesman will be able to answer additional questions as it relates to the medical review of veterans' claims if we get to that point. So I just want to sort of set the agenda that first Brady White will talk, then Brad Floor, and then also following that will be Alan Dinesman. I will tell you that we have a new handout which which Donna has ready to hand out, if Donna would hand this out right now. This is what we think is a near final copy of a new brochure that we're providing. This is information that will direct veterans and family members to both the 2012 healthcare law, the programs that are under that, but also orient to veterans' claims and the 8 presumptions. Should you have feedback on that particular prototype that we're handing out, please make sure that Donna gets that, because we want it to be as accurate as possible, and I mean that in all sincerity. We want to be able to, on a regular basis, get out the most accurate and timely information in this regard, not only on our websites, but in printed materials such as this. So she'll be handing those out. Thank you, Donna Stratford, very much. And at this point, I'm going to turn you over to Mr. Brady White.
Thank you, sir. So we, well, first of all, thanks for having us back. It's an honor to be here.
and to represent the family member side of the program. I am the program manager for that effort in the VHA, and I'm also for the veterans. I'd be a point of contact for you if you have questions about your health care benefits. So please see me afterward or during the break if you have any questions about either of those. Okay. So we're going to go ahead and get started. For the CAP members, you've seen this presentation before, but basically I'm going to go over some updated numbers, and we can talk about anything you'd like to chat about. The first slide, if you can switch over there. Okay, keep going. And keep going. I guess I set this up to go on the space bar. So this is the list of conditions that we cover based on the 2012 Gerry-Smeaner Act. And next slide, we start talking about veteran eligibility. And basically from August 1st, 53 to the end of 1987, a veteran has to have been stationed at Camp LeJeune during that cover time frame. Here's a very important bullet that I always like to point out is the veteran does not need to have one of the 15 conditions in order to receive health care benefits. Okay, so that's very important to keep in mind. They do not need a service-connected disability to be eligible for VA health care, and there's no cost to treating for any of the 15 conditions. We can still treat you for other stuff other than those 15 conditions. There's just going to be a copay for that. And that comes in as, the veteran comes in as a priority group 6 veteran and all the benefits that entails. The next slide deals with family member eligibility. And here we have to show a few things. We have to show dependent relationship with the veteran during the covered time frame. The family member has to have resided on base during that time frame, and they have to have one or more of the 15 conditions in order to receive reimbursement for that health care. Okay. And the next slide is where we get into some numbers. So keep going down to as of July 18th, we've provided care to over 44,000 Camp LeJeune veterans in the VA system. Over 3,000 of those were treated specifically for one of the 15 conditions, and over 600 of those were just for this fiscal year. And here we've got an 800 number that if any veteran has questions about their health care benefits, that they can call that 877-222-8387. Okay. And the next slide breaks down the care that was received by veterans based on those 15 conditions. Give you a second just to kind of absorb that. And the next slide, we get into the family members. So our program launched in October 24th of 2014. We had to wait until the regulations were published in order for us to actually start reimbursing family members. So we basically reimburse them for care that they receive, any out-of-pocket expenses, and we can reimburse for care up to 2 years from the date we receive your application. Okay, so make sure you save any of those receipts. And again, as of July 18th, we currently have as of that date, we had 306 family members that were actively getting reimbursed for care. And any family members that have a question, we've got a call center that's been set up in Austin, Texas. Number is 866-372-1144, and we also have a website. You can go and get some additional information. Okay, the next slide has a lot of numbers on it for the 15 conditions for the family members, and how all of the conditions break out for them.
See, most of it has been for breast cancer for the family member side. Okay, the next slide deals with denials. That's always a topic of interest for the CAP. So of the 44,000 plus veterans who applied, 1,336 were denied eligibility because they didn't meet the statutory requirements for a veteran. Okay. For the family member side, there were 52 waiting administrative determinations, and 681 were deemed ineligible. And I broke down the three main criteria for why that is. 327 because we just couldn't put them on base. We couldn't show that they had residency. 208 because there wasn't a dependent relationship. Maybe they were a cousin or a friend or something like that. And 123 because the veteran just was not eligible.
Hey, Brady, how many of these slides you got?
Just a few more.
Well,
Do you have questions?
yeah. Why didn't you make hard copies of these so it could be distributed?
I sent it to our contact here in ATSDR. So
Yeah?
I will make copies at the break.
Yeah, I mean, there's people taking pictures of these slides and,
I'll make sure we have enough copies for everyone.
okay,
Okay?
thank you.
Yes, sir.
sorry, I probably should have asked for that, and then I just sent it to you. So
It's okay.
I'll take
We'll take
ownership
care
of
of
that. The next slide deals with the top five reasons why we might not have approved a claim for reimbursement. The first one is the other health insurance basically paid for everything, so there wasn't any additional responsibility that the family member might have had. So that's actually the top one. The other one is a duplicate bill that was submitted. We can't pay for duplicate claims. The next one is basically it was for a claim that was not covered. It was not deemed to be for one of the 15 conditions that's under the Act. And the next one is in order for us to reimburse for care, we have to show that the family member, if they had other health insurance, that was put in place before we submitted. And then the next one deals with pharmacy drugs, and prescription was not covered by the approved formulary listing. We've developed a pretty extensive formulary. We actually hired a pharmacy benefit manager that we have a contract with, and the reason we did that at the beginning of the program was initially, if you guys recall, when we didn't have that in place, a family member would have to go to their pharmacist and pay out of pocket. And so we hired these folks, the pharmacy benefit manager, in order for that not to happen. And the next few slides just kind of show the communications that we've had. Mostly the purpose of this is to show that we've kind of partnered with the U.S. Marine Corps and got their assistance for mailing out letters. They've put various ads in newspapers and documents, publications around the country. And that is it. That's it for me.
What was the biggest statutory hurdle that veterans being denied? Was it not having enough time at Camp LeJeune, or what?
The biggest one was them just not being deemed a qualified veteran, probably dishonorably discharged, something like that. Yeah.
Hey, Brady, this is Mike Partain. I know we've kind of brushed on this before, but I do get questions and things that come up through our Facebook page, both for veterans and the family members, as far as treatments and stuff. What about residual effects? Like, for example, when you go through cancer, you have to go through chemotherapy, and that chemotherapy does damage, So like I forgot the abbreviation, but the codes for diagnosis aren't going to apply if you become diabetic or if you have neuropathy and you're on prescriptions for that after cancer. So how are you all handling those type of issues or secondary health effects due to treatment from the primary condition?
That's a great question, Mike. Thanks for bringing that up. And as CAT members know, I actually went through that myself. You know, I know the secondary effects from chemo and radiation treatment. And what we've done in our program to make sure that those conditions are covered is if it's deemed that something was caused by either the initial condition itself or the treatment for that condition, either one of those, then we're going to cover that expense.
Now, is it up to the individual to provide that documentation? Like, for example, I'll use my own personal. And I had breast cancer 10 years ago. I'm not actively treating for breast cancer, but as a result, during treatment, they had me on prednisone and other things with chemotherapy. I became diabetic. I also had endocrine failure, and then the other part of neuropathy, which I'm currently, all three issues, I'm currently receiving both medical care and treatments for. Do I need to go back to my doctors and have them write out notes, or how do you guys handle that?
Yeah, we would need some kind of medical documentation, and if the documentation doesn't itself point back to whatever the condition was or the treatment for that condition, then we do have a team of physicians in the it's called the War-Related Illness and Injury Study Center, RISC, WRISC. Yeah. There are a lot of I's in there. But we coordinate with them, and they may look at the medical docs and help us make a determination for that. So, but basically, we try to make it as simple as we can. And if we can show we have medical docs that show that the original condition or the treatment for that was associated to one of those 15 conditions, then the family member will not have any out-of-pocket expenses.
Tim, you have a question?
Yes, I've got three. First one on the priority group 6. I've noticed that there's quite a few people, including myself, that when you initially sign up are being placed into category 8, and in a lot of cases category 8G. What do they need to do to change that, to get the priority group changed?
My understanding on the veteran side for the eligibility process is there was some limitations to the system, and they're working through that to help make sure that that's more streamlined. But I do know that was an issue, and they have to manually flip that switch to make them a priority group 6.
Have they done that? Have they already done that, or are they just doing that manually, case by case?
It's done on a case-by-case basis at our Health Eligibility Center here in Atlanta.
Okay.
And if you guys want, I've tried before to reach out to them to have representative here. I can certainly do that again, maybe at our next CAP meeting if you'd like somebody from their office to be here to handle some of those kinds of questions.
That would be fantastic.
Absolutely.
Yeah, especially since they're here local. When we're having the group, it would be great for them to trot on over here and help us out.
Absolutely.
On the other health insurance, OHI, does that consider copays that may have been paid by them?
Yes, sir. Yeah. Basically, the way you can think of it is if there have been any out-of-pocket expenses for treatment of one of those 15 conditions, we're going to make sure we cover them.
Okay, great. And then the final one was you mentioned RISC. And those folks, I contacted them personally to see what type of assistance, what type of services that they may be able to provide to our community, given the nature of the illnesses and exposure and so forth in our community, and was told that they could not help anyone at Camp LeJeune. So if there's something that person happened to be missing on that, if you could fill that in, that'd be
sure.
Awesome.
And I'm going to let Dr. Erickson handle that. He kind of oversees that.
Okay, thank you. Appreciate it.
Yeah, Tim, thanks for bringing that up. The RISC, the War-Related Illness and Injury Study Center, which is located at 3 locations in California, New Jersey, and D.C., has in the past been primarily postured to deployment-related, sort of overseas wartime-related injuries and illnesses. They are making a transition this year, and it's a transition that is ongoing. They are starting to see more veterans who have been at a variety of military bases within the continental United States. We're developing new educational materials in conjunction with the RISC in this regard. So this is a work in progress. And I wanted to jump in on what Mike had asked earlier, and I think Brady answered correctly, but the physicians at the RISC who are helping us to work through some of these issues, such as the second and third order effects following chemotherapy for cancer survivors. We talk about this on a monthly basis in regular meetings, so we're very sensitive to that. It doesn't mean that we're always getting it right, so please help us in that regard. But, Mike, the issue you brought up is very appropriate in that one of the covered conditions may well have second and third order effects downstream that need to be covered as well. Thank you for bringing that up.
Thanks.
So would they need, would the individual, let's say, that wanted to try to get an evaluation through RISC or some additional work, would they need to get a referral from their doctor to that, or is there a process involved?
So as it relates to those who, and we're talking in this case not family members, veterans, okay, because the family members could not go to the VA facility. But for the veterans who were in particular perhaps more complex cases, we sort of look at the RISC as being sort of like the Court of Appeals. We work to the greatest extent we can with the local facility to equip those providers with the best information, and we provide electronic consultation, for instance, sometimes real-time discussions back and forth as to the best way to evaluate and treat various Camp LeJeune veterans. But there are some cases that now we're interested in perhaps bringing them in person. We have what's called a national referral program, but it's not necessarily that everybody goes, because that would sort of swamp the system. But for the most complex cases, that's what we intend to do. Yeah, no, I really appreciate you bringing that up, because again, this is an area of growth and expansion for us.
Thanks. Mr. Orris, you have a question, then we'll go to Mr. Wilkins.
Yes, actually, I have 3 questions, and we'll kind of start them off. Brady, I usually ask this. How much did your family member benefit program cost, and what was the cost, and what were the benefits that you paid out? I'll let you answer that first.
You're right. You have asked that, and I don't have a placeholder for that. I need to do that. I don't have that at my fingertips, but I can certainly provide that after this meeting. So that was basically the cost for the family member. I can also provide it for the veterans, if you'd like that as well.
I would like that as well. Second question, how much has your program paid out to anybody born with a congenital heart defect at the base?
That would be 0.
And that's because it's not on the list, correct?
Correct.
And what has your department done to add that to the list? What efforts have you done?
Dr. Erickson, you want to tackle that one? Sure, and I'll try and answer this, but look for an assist from Jerry Ensminger. Because the inclusion of family members is based on legislation that is very closely confined, the VA is not able to work outside that list without Congress basically amending the law, which I understand is underway. Jerry, I don't know if you want to comment.
Well, the appeal is there, not the appeal, but the bill, the amendment, to amend the act, and it's waiting for a markup hearing and then a vote. So I don't know when that's going to happen. I can find out when they're going to have a next markup hearing in the VA committee, and it'll be in that markup hearing.
And will the VA support that in the hearing?
So what typically, I'm going to answer broadly first, Chris. I know you already know the answer to this, or at least part of the answer. So as a federal agency, of course, we don't independently advocate for or against legislation. However, we will be requested to provide cost and views. And in particular, we will tell you that we have, I would say, regular contact with members on the Hill about these issues. We have a very active Office of Congressional Liaison. Danielle and I were just talking about that. And so these things involve lots of discussions. That's probably as much as I can say at this point. I hope that's not totally unsatisfying.
Well, when you add the benefit, it'll be satisfying. And a third thing, I forwarded an email back in June to all of you in regards to a visit I had at the Durham VA. I'd been there for my father. He was receiving some treatments. And I happened to speak with a VBO there in Durham, sat down in her office. I'll keep her name out of this for now. However, she had informed me that she had limited LeJeune informational supplies and had actually asked me to reach out to the VA to get more informational supplies to give at the Durham VA. And she had also told me that she had no posters. There was nothing in her office about the exposure at Camp LeJeune. And I'd sent this over to you, and your response was a May 4th email that said that you were planning on working on that. Well, you know, that effort has failed as a result of what I saw there at the Durham VA. You would certainly expect your VBOs at this point in time to know everything there is to know about Camp LeJeune and to give those veterans the benefits that they deserve. What are you doing to fix that?
Thank you for bringing that up. On the effort to put more information out to the medical centers, our communications manager has been working through the system. You know, we have a bureaucracy here, and the wheels turn slowly sometimes. But he has, I know personally, because I ping him on this every couple of weeks about where we are, what's going on. And my understanding is that poster has been rolled out to the, I guess, every medical center and VISN, regional office. They've got personnel that are kind of in charge of that. So we've rolled that out to them, and then it's kind of up to them to then print it out, put it up on the walls, put it up in the TV monitors that they have. You know, we can't really force their hand on that, but we've made it available to them for them to make sure that they communicate that.
Just real quick, and we call out the bad, but we'll also call out the good here as well. I'll just mention that at Topeka VA, at the eligibility, they had a nice little sign that was talking about Camp LeJeune right up front for everybody to see. So they're doing it right.
Well, Kevin Wilkins had a good idea, and you guys got these TV monitors in the waiting areas in all these VA hospitals. Why not make slides or a tape of these posters and the information on Camp LeJeune and insert it into the loop on those ITVs?
It's at the Washington, D.C. VA, for the record. I'm there 3 times a week. It's on the roll screens, and they have posters up.
Yeah, so it's kind of, unfortunately, there's hundreds of hospitals and clinics around the country, and some of them seem to be doing it correctly, and some of them we can probably work on. But if you have specific ones that aren't, we can certainly inquire. Because the TV is part of it, Jerry. It's, getting that information on those monitors. I don't know if they're in every hospital, but, they're.
Well, I mean, the secretary of the VA, I would imagine if he ordered something like this to happen, that it would. Mm-hmm. I mean, it better. I mean, hell, if I was the secretary of the VA and I told somebody to do something and they didn't do it, they wouldn't be there the next day.
Everything you guys are saying is greatly appreciated. There's the top-down strategy that we're working that it sounds like in some cases is being put into effect appropriately. Electronic things that we're sending out posters, et cetera, training for these individuals, whether it's on the benefit side or the healthcare side, the risk ramping up, regular meetings with environmental health coordinators, clinicians. But using that military model, you guys know that I'm a veteran myself. When you guys help us identify, and I hope we didn't drop the ball, because I thought I contacted Durham directly, but I wrote it down again, Chris. We can make on-the-spot corrections. We can use that military method to say, okay, guys, we just got contacted. Why are you guys not with the program? I mean, we don't want to burn any bridges here, but we'll work with those folks that perhaps aren't doing what they need to. Understanding big bureaucracy, 370,000 employees, people don't always do exactly what's the perfect response to veterans, and I apologize for that, but we want to make it better. Here's something really cool that I want to share with you. VA is going through a modernization effort right now to be redesigned, and you've seen this in some of the secretaries' speeches. We're all engaged in that to deliver health care in a more efficient and appropriate way to veterans. You probably have heard about the CHOICE program, et cetera. Post-deployment health services, which is my domain, which includes the Camp LeJeune issue and the risk, we have actually been designated as a VA-delivered foundational service. And this will take effect in this next fiscal year. And so I will tell you that we are, it's not that we've been the Rodney Dangerfield, don't get me wrong. I think we've been getting attention, but we'll get more attention, Chris. We'll get more oomph, if you will, to be able to affect our programs. And so there's good news in that.
Yeah, two things real quick. If, on our Facebook pages, we get veterans that every so often come in and say that they've been to a VA facility, talked to somebody, and was turned away or had no idea. When we see that, who do we tell them to go to? That's one. And the second part, are we going to be discussing the presumptive and the SME issues? Because I got some things I want to bring up on that when we get to it. I don't want to jump the gun.
So the quick answer is at the local level, they would ask to see the environmental health clinician or environmental health coordinator. And these are two positions that are designated for all medical centers. And that would be mine. I mean, you could send me an email. I may not be as responsive just because of the crush that would come, but on the local level, environmental health coordinator, environmental health clinician would be your starting point.
I think Mr. Wilkins has a question.
Yeah, Brady, when did you, it said in 2017 you sent it out to the hospitals in the C-box. When did you do that?
So right after this last CAP meeting, I started coordinating that effort with our communications officer.
Okay. We still have a problem in Louisville. Debbie Belcher, your environmental coordinator there, I made visits last week, and she's got a little sign made on a copier that says Agent Orange, contact Debbie Belcher. It's right beside the video monitors. There's no mention of Camp LeJeune on the video monitors. And that was last week.
Okay.
But
so that sounds like one of those hospitals that may not have quite gotten the word yet we can reach out to.
Be sure to use your microphone because I don't think it's coming through.
Debbie Belcher says the VA is not doing anything for Camp LeJeune.
Well, she's not right. She's not correct.
Well,
if Louisville doesn't know what the hell's going on, who does?
Well, Jerry, you heard it in here from several other people that they are doing it right. So we can reach out to those that aren't and, make sure that they get the message.
Yeah, but Louisville was the focal point for Camp LeJeune. I mean...
Okay, so two pieces at Louisville. One is the medical center, which I think is what Kevin's referring to. The other is the regional office for benefits, which is the focal point for benefits. And why the two are not talking at that location, I don't know, but I've written this down, and we'll try and work it.
Thanks. Mr. Ashley?
Brady, quick question. What's the turnaround time for reimbursement?
Believe your question deals with once a claim has been submitted?
Right. Once a claim has been submitted and approved, what's the turnaround time?
Yeah. Our goal is, I think, 90-something% within 30 days.
And Do you have any numbers on how long it takes to get an application approved? 30 days, 60 days? I'm sure it's dependent on the applicant providing all the necessary information,
Right.
crossing the Ts, dotting the Is.
Yep.
What's the average time for that? Do you know?
I don't. Yeah, so when we started this effort, one of the first things we did was we developed some metrics to see if, how well we were doing or where we needed help in. We've got all kinds of timeliness metrics, quality control metrics, things like that. The 90%, I think it's 98% within 30 days for paying the claim is one of those. The timeline for processing an application, that's kind of tied into our system that we've built. And unfortunately, I have not ever gotten the money to finish building that system. So we're only about 50% complete. So I can't put my hands on that data point at this point in time.
I guess.
Well, we receive used to be about 10 applications a week. Now it's roughly around 20. And, we are, we're not getting complaints from people about not having their application done timely. So just anecdotally, we seem to be on top of that.
Okay, good. Ms. Carrazza, and I think you have another presentation after this, so 2 more. So we'll probably wrap up Q&A and then move on to those presentations.
I just have a sidebar question. Last year, we discussed the clinical diagnostic guidelines that were developed. I'd actually seen a hard copy. We've had administration change since then. Has that been completed? And if it has been completed, is it available to the public? And I ask that from a family member perspective. It helps us to take it to educate our doctors and also to be able to refer our my VA doctors back to something to say. I noticed scleroderma picked up a lot on the family members. And that's something a lot of doctors don't know about. So it would be very helpful to have a core document to point them to.
Yeah, thank you for that question. I was hoping someone would ask. Deep sigh. Even this week and last week, I spent time with General Counsel, and as is so oftentimes the case when policy documents are written within our agency that involve complying with legislation, there are people who understand legal words much better than I do, and they're known as lawyers. And we don't have clearance yet of that document, but I do want to speak to that. The particular document you're talking about is a guideline. Now, it's not a clinical practice guideline. This is probably important for everybody to know. A clinical practice guideline would be a document that would assist any provider in VA or outside of VA in actually diagnosing and treating a Camp LeJeune veteran or family member. This is not a clinical practice guideline, so it's not guiding the practice, the clinical practice. What it is, this document is a guideline that helps us interpret in medical terms the 2012 law so that we are fair and thorough in how the medical examiners at the risk that Brady was talking about review the claims and then hopefully move in a fairly expeditious fashion to then provide health care for veterans or to provide reimbursement to the family members. I'm frustrated that this is not out yet.
I know we're going to go on to the next presentation.
Yeah.
But if anybody has any more questions for the family member program or VA healthcare benefits, please see me during the break or at the end of this.
Right, and for further questions, probably during the break, you can field some of those as well on this. So,
Can I ask one more now?
real quick one, sure.
Brady, now that we've identified Debbie Belcher making her homemade signs for Agent Orange, do you think we could have the Camp LeJeune stuff on by Wednesday?
I'm sorry, Kevin, I couldn't quite hear your question.
I said now that we've identified, do what? Now that we've identified Debbie Belcher, and it's on. Now that Debbie Belcher's been identified in Louisville for making her homemade signs for Agent Orange, do you think we could get the Camp LeJeune stuff in the media services by maybe Wednesday?
Wednesday is tomorrow?
Yes.
Yeah, we'll reach out to her, Kevin, and make sure she knows that these materials are available, and it'd be a good service to our veterans and their family members to put those up.
She's making homemade signs about Agent Orange, so I mean, the Camp LeJeune stuff, and she's known about it for 5 years because I've brought her up to date a few times, but it goes nowhere with her.
Okay. We will follow up with her. And Debbie Belcher?
Belcher.
I think we better move along with the next presentation, given the time.
Good morning. Brad Floor from VBA's Compensation Service. I'm glad to be here today. I appreciate coming to these meetings. I've been coming to them since January of 2011. I think I've only missed one or maybe the most two during that time. As you know, on March 14th of this year, we published a final regulation creating a presumption of service connection for 8 diseases that have been associated with the contaminated water. I want to take this opportunity to thank ATSDR, Frank and Perry and Dr. Bricey in assisting us in coming to that determination. The areas, of course, the requirements in the regulation is a veteran had to have served 30 days or more at Camp LeJeune. Camp LeJeune includes MCAS New River, Camp Geiger, Camp Johnson, Naval Hospital, Tarawa Terrace, Camp Knox, Montford Point, Stone Bay, and the Rifle Range, Holcomb Boulevard, and Hadnot Point. So anyone who serves there for a cumulative period of 30 days or more, it doesn't have to be consecutive, but just 30 cumulative days, are entitled to the presumption of service connection for one of the 8 conditions. We started working claims at that time on March 14th. As of just earlier last week, we had completed 3,378 claims since March 14th. We have granted 2,498 of those, denied 917. The reasons for denial generally is the veteran didn't have 30 days at LeJeune, or they didn't serve at one of the, a lot of them, they didn't have actually a presumptive condition. They filed a claim saying they have a presumptive condition, but when we looked at their medical evidence, it really wasn't. So those are the reasons for the denials, but obviously we're granting about 75% of those claims so far. We still have 2,700 pending claims for presumptive, and we're working through those as quickly as we can in Louisville. When this regulation became final, I became interested and concerned about appeals that were pending for one of the 8 presumptions. I identified 12 that were pending at the Board of Veterans Appeals, working with a colleague of mine there, and they granted each of those claims from March 14th. Those appeals will still be pending because when they're decided, some of them may be approved and the veteran will get an earlier effective date or a survivor, whichever it may be. We also identified 317 appeals at Louisville, which have not yet made it to the board or in our appeals management office, and we're working now with the Office of Field Operations to get those rated and granted effective March 14th. And hopefully we'll have those worked very shortly. Again, those appeals will continue. The appeal won't end, but we wanted to, it didn't make sense to me to have an appeal pending for 2 or 3 years before the board decides it when we can grant it for March 14th. So we're working on that.
Thanks.
Under the rule authorized local VA officials to approve these presumptive conditions.
Correct.
Why is everything going to Louisville?
Well, I'm sorry, they're not, but the appeals are at Louisville.
Okay.
But our regional offices are working the claims for the presumptions.
Mr. Orris?
How many veterans or their family members have been denied because of an other than honorable discharge?
Oh, gosh, I have no idea, Chris.
I would like an answer to that. I think we established last time that water contamination is not an issue that's dependent upon a veteran's behavior. And certainly a family member or a spouse should not be punished after being poisoned?
Well, you just basically by law and regulation, a veteran has to have been discharged under conditions other than dishonorable before they're entitled to any benefits.
So that sounds good when you say that. That's just an excuse.
That's
But
not an excuse, it's
when,
law.
When we poison people,
It's
and
the
then
law, Chris.
That's fine. I want an answer.
I'll see if I can get an answer. I don't know. We have that information, but I'll see what we have.
Mr. Templehead?
Yes, thank you. Hey, Brad, are we going to get a handout or something with those statistics in it?
I can
Or
send them
email?
to Jamie. She can-
Super, that'd be great. Another question: are there any Camp Lejeune cases that you're aware of having to do with the contamination at CAVC?
I'm not aware of any,
Okay.
but I can check with the general counsel that is the CAV staff.
Super,
See
I'd
if they
love
have
that.
any.
That would be great. And then one last question here, and this is something that's been brought up by several members in the community. Apparently, there was some backdating in the last CAP meeting that we have. I know you'd expressed some concern, some interest in following up on backdating prior than March the 14th for certain claims, for some claims, and I know it sounds like you kind of broached upon that in your presentation here too. So some people apparently are a little confused as to where that's going, or whether it's already been put into effect, or whether there's something coming down the pike that might occur.
I'm sorry, I missed your question, I think.
It was in the last CAP meeting. I know you'd mentioned something. I reviewed the transcript here too to see that you had mentioned that there were some issues that you wanted to follow up on regarding backdating of some of those presumptive claims prior to March the 14th, and and that there may be some activities that you might have been at least interested in pursuing in at that point.
No, that we cannot pay benefits prior to March 14th
That's
unless there's an appeal pending. An appeal grants on a direct basis rather than a presumptive basis, then it would go back to data claim.
Okay, and that's what we had heard prior to that, and so that's why it stuck out really like a sore thumb in the last the minutes of the last CAP meeting. So I just wanted to see if we could make sure that we got a clarification of that. Yeah. Some people on social media were particularly confused by that.
Okay.
Thank you.
And Jerry, you made a good point about Dr. Schulk, and as Dr. Erickson said, we'll be meeting with him in a couple of weeks to talk about Camp Lejeune. He's going to want to know what is going well and what is not going so well. And we can mention that, bring that up to him, because those are the kind of things he wants to know.
Mr. Orris, did you have another question? No. Okay.
And Chris, if I could just follow up on that comment about the other than honorable, and I believe I misspoke earlier. When I had the slide up showing the number of family members that had been denied is 123. I actually believe most of those were because of they were just there for training, or maybe on as a reserve, something like that. But what we can do is I can try to break those numbers out.
Thank you for the clarification on that. And Brad, I just want to point out, it was also the law not to poison people at Camp Lejeune.
Oh, of course. And I also should let you know, Chris, that we are working on making some changes to other than honorable discharges. That's being looked at.
I saw that for the mental side.
Yeah. Yes.
Hey, Brad, I mentioned earlier I had some questions about presumptive and everything. On the social media, we see things like there's a gentleman, William Barch, who was granted presumptive service connection for non-Hodgkin's lymphoma. Thankfully, from gathering from the Post, he's in remission, but he was given 0 rating, which would be somewhat correct. But what about residual effects, again, from treatment? Because he's, in this case here, he's claiming he's had issues that are post-cancer that are related to the chemotherapy and treatments and stuff. And I'm still confused, even Brady mentioned, when you go through chemotherapy, you're not the same. And I have a hard time understanding how the VA can grant somebody who's gone through cancer, gone through treatments, a 0 rating. Yes, the cancer may be gone, but sometimes the cure can be worse than the disease. And then I've got another one to follow up on this.
I got to tell you, Mike, to my memory, I haven't rated a claim in a long time, but I know in the rating scales, generally, if a cancer goes into remission, still they should be evaluated at 10%. If it's completely in remission. Now, if they have other disabilities that arise because of the treatment or whatever, we should also service connect those on a secondary basis and evaluate them based on their severity.
Then who they go, I mean, he's wanted to go for an appeal, and other people said, contact the VFW, American Legion, what have you. But, I mean, my question is, we've brought this up before. Why is this still happening? I mean, that's to me, that's a training issue, and it shouldn't be happening. We brought this before in CAP meetings, and I see this over and over again. The other issue is another Marine. His name's Frank Hernandez. He has end-stage kidney disease, and he's on dialysis 6 times. I think he said 6 times a week here. Let me find it on here. But he's on kidney dialysis. He says 6 times, 3 times a week, what have you. But the point here is, this is not a condition that was presumptive category, but kidney cancer was. And going back to the 2015 IOM report that you guys requested, one of the recommendations in that report, which seems to disappear and never get talked about, was that veterans should be given the benefit of the doubt for kidney disease. And yet here we are still fighting this battle. What's the status on that? Are we going to be adding kidney disease back into this? Or, I mean, we still don't understand why it was left off in the first place. And the other one was what, Jerry, scleroderma?
Scleroderma and end-stage kidney disease. And we know that OMB dropped off scleroderma, but it was the VA that dropped off end-stage kidney disease, and there is sufficient evidence. I mean, that was in ATSDR's review, and it's also in the IOM report that you guys asked for. So the scleroderma part, I know you can't do anything about that, but you can do something about the end-stage kidney disease, and you should do something.
And just to point in here, let me read Mr. Hernandez's post. He has, fellow Marines, I'm also battling with the VA. I have renal toxicity. I received my first notification letter 5 years ago that said in bold letters from the Commandant of the Marine Corps saying that we take care of our own. What a joke. The VA found every excuse to deny my claim. Been on dialysis for 6 years, 3 times a week, with complete kidney failure. Through my veteran rep, no help. With the DAV, no help. The same situation as most of us. What's our next step? If anyone can come help us with a solution or come up with a solution, let me know. Little did I know that the Marine Corps would leave me as the walking dead.
Well, unfortunately, Mike, whether or not kidney disease or other than kidney cancer gets added to a presumptive list is something that would not happen for a while, as it takes time. But the best thing this veteran can do, of course, is send a medical statement saying it's at least as likely as not that his kidney disease resulted from his service at Camp LeJeune, and send that to the benefits office for them to review it again.
I mean, this has been, like I said, the 2015 IM report, I mean, that's 2 years ago. I mean, it's just mind-boggling. I mean, and by the way, what is the new name for the SME program? I heard it's been renamed for Camp Lejeune. Because that's a, you ask a veteran to send a nexus letter in to the VA to have their claim looked at, and then it goes to the subject matter expert or whatever name the program is now, and
I don't know if the name has been changed. Dr. Dinesman might be able to.
Okay. Well, then the SME shoots back to his doctor, prove what you're saying, provide the medical literature support, and it just gets. You guys commissioned a report with the IOM, and the IOM says give these people the benefit of the doubt. Why are we having this argument?
I agree. I don't know. Maybe Dr. Dinesman can shed some light on that.
Well, speaking of SMEs, one of my favorite punching bags. As you all know, we have a lawsuit against the VA in federal court in Connecticut. Yale Law School is representing the veterans organ groups. And we have been continuously denied access to the names of the subject matter experts for Camp LeJeune. Just recently, I saw where the Arizona Daily Star had submitted a request to the Tucson VA Medical Center for the names of not only their dermatologists so they could check these people out and see what their qualifications were, but all the clinical specialists. And they were initially denied, just like we've been denied the names of these people. And on June 15th, the paper down there submitted an appeal, and the VA's legal system came back and approved it. It said Exemption 6 would allow the VA to withhold such if there were an articulable threat to the privacy or safety of the individuals. Upon receipt of your appeal, we contacted the VA Medical Center to ascertain the basis for withholding. While we find the dermatologists have a personal privacy interest in their identities, there is a countervailing public interest in knowing that VA employs qualified individuals. As such, we find that public interest outweighs the privacy interest of the providers in this case. Why are we different? Especially with people that we know have made some outlandish opinions on cases. These people had no business even being subject matter experts. And you've got people now, I've got a list of the qualifications that was redacted, who have no toxicological or epidemiological background at all, who are subject matter experts. I mean, like I told you before, I don't have a problem with you having a subject matter expert program, but damn, hire subject matter experts.
In addition to that, to piggyback on what Jerry just said, and the reason more than likely why the Arizona paper was able to prevail in that case, is that it is in the regulations that anyone who is being judged, in this case evaluated for a claim, that they have the right to be able to know who gave that evaluation and what their credentials were, to look up those. It specifically states that.
This is Ralph Erickson, and let me just mention to Alan Deinsman. Alan, you're going to be up in just a second here, but I want to take the first part of this. You guys, you'll see this in the news all the time. We really can't comment on ongoing litigation. I mean, it's just, we need to be able to go back to our jobs without losing our jobs. But we're certainly aware of that lawsuit. Let me just say that I know that there are a number of steps right now that are underway within the Office of Disability and Medical Assessment to tighten up things within the subject matter expert program. And Alan, I wonder if you can talk about if there's been a name change to that program and maybe talk about some of the changes in the education that's going on.
Yeah, thanks, Warren. There has been no name change that I'm aware of. The
thanks. You know,
The case has been resolved.
And some people at OGC ought to be informed of that specifically because they're still participating in that conduct.
I think the point's been taken at this point, and we have one more presentation, and given the time, I'd suggest that we move forward with that, if that's okay.
Yeah,
Unless
thank you.
have final wrap up on this.
So, Alan, can you speak to some of the things that are ongoing within the Office of Disability Medical Assessment that relate to education, et cetera? You're the last presenter.
Are we going to be able to get a revised bibliography of the studies and literature materials that are provided to the SMEs for their background knowledge? I know this has been an issue in the past.
Yeah, we don't believe applying the bibliography will landmark studies, for example, the ACFCR publication. With any of any situation where you're going to independent medical examination, medical opinion, it is up to the examiner themselves to make sure review all of the medical literature and make sure
This is Jerry Ensminger, Dr. Diamond. I would like to see the list of the studies that you're providing to these people. That is very important. Yeah. Why not? It is what? I mean, they're public documents. But I want to see what you're providing these people as legitimate studies, and that's not asking too much. Yeah, well. Well, I mean, you should be constantly updating us, the veterans, the people that are being affected, have been affected by this, with a list of the studies that your so-called subject matter experts are using to make these opinions from. No, not what you're providing. We want to know what you're providing to these subject matter experts for them to use in their opinion making.
I mean, look at. No, that is not correct, because in the past, I know Brad and Dr. Erickson have talked about a bibliography, and I believe you even mentioned it in the 2015 hearing, if not mistaken. Now, there is no reason why this bibliography or reference of studies or whatever manifestation that you want to change that to can be publicly listed on a website so the veterans know what these SMEs are looking at. Now, there's just no reason for it. And if it put it publicly on the website, have it updated as it's changing, monthly updates or bi-monthly or whatever. But we need to see this list of what's being out there.
Well, and in all reasonable, in a reasonable world, any SME that writes an opinion should cite the studies that have made them come to the conclusion that they've come to in their opinion. That's just science.
And let me go ahead and cut through the smoke screen real quick here. We received some documents on the Yale lawsuit that showed that there were templates that have been created for the SME program. In those templates, it does cite studies and so forth for an SME to do an evaluation on. So you are providing information to the SMEs in a canned format.
Let me, can I just jump in real quick? Let me ask that, Jamie, if you make sure this becomes a do-out for the next meeting, okay, that Office of Disability Medical Assessment provide a formal presentation that will update where the SME program is at as it relates to training, credentials, bibliography, so that we have an updated answer for you here at the CAP.
Mr. Ashley, one quick last question, and then we'll move on to the last presentation.
Okay. Actually, it's not a question, just some observations and comments. Brady, you had mentioned that the wheels of the bureaucracy turn slowly with respect to ensuring that all of the VA facilities around the country are aware of Camp Lejeune veterans and the things that the VA is supposed to provide for them and the new laws that have been passed. And there have been a lot of successes and probably some documented not successes. Are any of you three guys Vietnam veterans, Vietnam era veterans? Okay. So you know what it was like back then, both the way the country treated us and the way the VA treated us back then. When I went for my orientation, the head nurse stood up and she asked how many Vietnam veterans were in the room. And we all looked at each other and we all had the same thought. Here we go again. And her father was a Vietnam veteran, and she apologized for the way Vietnam veterans were treated. And you know what? It changed the bitterness in my heart and everybody else who was a Vietnam veteran in that room. Whenever a Vietnam veteran is turned away because the bureaucracy is turning, the wheels are turning slowly, that bitterness just gets compounded in his heart and all of his friends who were also Vietnam veterans. So, you know, there needs to be a focus on making sure that all the VA clinics around the country, whether they're hospitals or even two-person clinics, that these people are aware of what went on at Camp Lejeune. And when a Camp Lejeune veteran walks through the door, especially one from the 60s or 70s, which is the bulk of those veterans, that they're treated fairly to turn around that bitterness, because a lot of guys and men and women still have that bitterness in their hearts. So with all that said, I really disdain the bureaucracy and the wheels of the bureaucracy turning slowly. If that, you know, with respect to veterans, something needs to be done more quickly to get the word out. These guys, these men and women need to be treated fairly. So whatever you guys need to do or however you can advocate that, that needs to be done more quickly. Thank you.
Yeah. Now, I heard something while I think Dr. Neinsman was talking. I heard the word IME, or independent medical experts. Is it the VA's position that the SMEs are independent medical experts? Because I do have an issue with that if that is the case.
Yeah, IME is independent medical examination.
Okay.
But just to ask you guys, I mean, are you, because I've seen this before with the documents that are coming out that we're seeing, you know, are the IMEs, I mean, the SMEs, in your opinion, an independent medical expert? Or, because they do, in fact, work for the VA.
It might be that Alan has a quick answer, but I asked that be rolled into the do-out for the next meeting so that we can come prepared to describe the parameters under which these individuals operate. I think that's a great question.
Yeah. And let's move on to the last presentation. This is it. Okay. Okay. Any other discussion? Break time. Okay. We can break now. We'll break until 10:35, so that's 15 minutes. Return at 10:35.
Provide you with a link to the update.